Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
Today, I will be discussing the journal article titled Prophylactic Administration of Vasopressors Prior to Emergency Intubation in Critically Ill Patients. Throughout this presentation, I aim to first go over some of the current knowledge we have on peri-intubation hypotension and its management, and then we'll go over the study design and results, and then discuss clinical implications of our journal article. So to start off with a little bit of background, peri-intubation affects up to 40% of our intensive care unit ICU patients and emergency department patients who receive endotracheal intubation. It can be manifested in many different ways, and some of the studies describe this peri-intubation hypotension or cardiovascular instability as either a systolic blood pressure of below 65 millimeters mercury at least once, a sustained blood pressure below 90 for more than 30 minutes, new or increased need for vasopressors, or a requirement of a fluid bolus. Like I said, a lot of the studies that look at peri-intubation hypotension and the agents we use to prevent it use these criteria to define cardiovascular instability and hypotension. And hypotension within the first hour of intubation is associated with higher mortality and longer length of stay. In a retrospective study of critically ill patients at Mayo Clinic, the overall hospital mortality was higher by 20% in those who had post-intubation hypotension. Some risk factors that can lead to or predispose a patient to post-intubation or peri-intubation hypotension include vasopressor use immediately prior to intubation, which makes sense because these patients are most likely at high risk of being hypotensive and requiring pressors. Risk factors also include the choice of induction agent, with etomidate being one that is commonly implicated in hypotension. Additionally, patients who present with acute respiratory failure or cardiac arrest, higher Apache 2 or SAPS-2 scores, and overall higher severity of illness are at higher risk for hypotension purely from their disease states. And finally, patients who are above 60 years of age are at higher risk as well. So in preventing peri-intubation hypotension in our emergency departments and our ICUs, this tends to be more provider-specific or institution-specific regarding what agents we use. It's more clearly defined in the operating room, where we often see things like phenylephrine and ephedrine that are used at push doses as needed in response to hemodynamic changes in our patients. In the emergency department where I practice as a PGY2 resident, I see a lot of push dose phenylephrine, as well as sometimes a request for epinephrine. However, the role of these agents is not clearly defined in the guidelines, and as a matter of fact, the SCCM rapid sequence intubation guidelines state that there is insufficient data at this time to support the use of peri-intubation vasopressors for the purpose of preventing cardiovascular collapse in RSI. Of course, when a patient is looking like they may become hypotensive or at risk for that, we do tend to try to use agents to prevent that, but we don't have very clear guidance in the literature on what agents we should use, which are better, and what the potential side effects or long-term outcomes of those are. One of the larger studies that the RSI guidelines quote is the INTUBE study, which is the International Observational Study to understand the impact of best practices of airway management in critically ill patients. This was a multinational prospective cohort study that looked at 2,760 patients in ERs and ICUs who received tracheal intubation. So they looked at 197 different sites and aimed to quantify the adverse effects that come along with tracheal intubation. They saw that 42% of all of their overall patients experienced an adverse cardiovascular event, with most of these being hypotension. In this study, pre-intubation vasopressors and pre-intubation fluid boluses did not reduce the incidence of intubation-related hypotension. And because of this study and a few others that I will not be mentioning today, the RSI guidelines do not expressly recommend the use of prophylactic vasopressors in patients undergoing intubation. Which brings us to the study at hand, which, as I mentioned before, was published in July of 2023 in Critical Care Explorations. This journal article's purpose was to examine the association between the prophylactic vasopressor administration and the incidence of peri-intubation hypotension in the ER and the ICU. And so this is intended to add to the body of literature specifically to patients in the ER and ICU and narrowing the focus of the cardiovascular complications specifically to hypotension, which is what we tend to try to target when we're giving these agents. For methodology, this was a retrospective post hoc analysis of two prospective multi-center randomized clinical trials, which were the BOUGIE 2021 and the PREPARE 2 trials, which I will be briefly going over here in a moment. So both of these studies were conducted by the same research group, the Pragmatic Critical Research Group that's based in Colorado. And between these two studies, there were 1,873 patients who received endotracheal intubation across 17 ICUs and 7 emergency departments across 24 hospitals in the United States between February of 2019 and May of 2021. The data in these studies, they had this data collection form that included a spot to record data on the use of prophylactic vasopressors as well as blood pressures in these patients. And so because of this, both of these studies had data that our current investigators were able to pull from. It's important to note, though, that these two studies were not expressly evaluating the use of prophylactic vasopressors. They just happened to have the data that we were looking for. And in both of these studies, the vasopressors were given at the discretion of the clinicians. The doses, the parameters were all at the discretion of the clinicians taking care of the patient at the bedside. So going a little bit more into detail about these trials, the first one is the BOUGIE 2021 trial, which evaluated the effect of using a bougie compared to a stylet in rates of successful intubation on first attempt amongst the critically ill emergency department patients getting tracheal intubation. So this was a randomized controlled trial of 1,102 adults who were getting intubated, and they looked at patients across 7 emergency departments and 8 ICUs across the U.S. The median age for these patients were 58, and they were mostly male. And again, they were primarily looking at just the first attempt successful intubations, and there was no difference between the two styles. However, in the background and some of the data that we're interested in for the purposes of our current journal club, they saw that 12.2% of patients in the BOUGIE group had cardiovascular collapse compared to 16.7% of those who had the stylet. This was not statistically significant. In the study, they defined cardiovascular collapse as a new systolic blood pressure below 65 millimeters mercury in the first 2 minutes, or the need for new vasopressors in the first 2 minutes, or a cardiac arrest within the first hour of intubation. Also to note, these patients, amongst the overall group, 69% of them received etomidate and 33% received propofol. The next study that our journal club authors drew data from was the PREPARE 2 2022 trial, and this compared the effect of giving a fluid bolus prior to intubation and seeing if that helped prevent cardiovascular collapse. So this had a little bit more to do with the current outcomes that we were looking at in this new study that we're evaluating. So here they looked at 1,000 adults receiving intubation across the same patient population, essentially. These patients were at a median age of 62, again, mostly male, and their primary outcome of cardiovascular collapse was defined as either a new blood pressure below 65 in 2 minutes or a new or increased need of vasopressors within those first 2 minutes after intubation. What they saw was that when patients received a small 500 milliliter bolus, they still had a higher incidence of cardiovascular collapse to those who did not. This was likely because the patients who did receive a bolus were already at higher risk, most likely were sicker to begin with, and were predisposed to hypotension, regardless of whether or not they were going to get intubated. Of note, only 12% of these patients were on vasopressors in the peri-intubation phase. 77% got etomidate, and 10% received propofol as their induction agent. most of these patients were not hypotensive at baseline, but when you look at their baseline characteristics, they did have illnesses and other factors that predisposed them to hypotension at the time of intubation. So for the present study that we're evaluating, this was a propensity score match retrospective cohort. So they pulled all of the patients from the Bougie and the Prepare2 trial, and then found all of the patients who received prophylactic vasopressors, and then matched them on a one-to-one basis to patients who did not receive vasopressors, but did have similar baseline characteristics to the patients who got vasopressors. And so they matched them based on what they called the conditional probability of receiving vasopressors, which were based on these 13 factors that I've listed below. So these were patient age, whether or not they had a history of hypertension, CKD, COPD. They matched them based on the severity of illness based on their Apache 2 score, whether or not they had a sepsis diagnosis that may have led to the events leading to intubation, whether they were a trauma patient, COVID-19. They also matched patients based on their pre-induction oxygen saturations, blood pressures, whether or not they had a vasopressor infusion already going prior to intubation. They matched based on induction agent, bag valve mass ventilation receipt, as well as enrollment in the Prepare2 trial, which, as I mentioned before, involved patients potentially receiving fluid boluses. So they determined a satisfactory match as a patient having a less than 0.1 standardized mean difference to their match. And so they really aim to match patients across all 13 of these covariates so that any patient who received vasopressors was very closely evenly matched to a patient who did not receive vasopressors, and we could control for all of these covariates. The population in question included adult patients who were either in the Bougie or Prepare2 trials who received endotracheal intubation with planned use of sedation. They excluded the same patients as the two Bougie and Prepare2 trials excluded, with the addition of one other criteria, with that being cardiac arrest preceding intubation. And this was because when a patient does experience cardiac arrest, it would have been very hard to really evaluate hypotension in that setting, since we've moved on to more of a code situation. So to recap some of those exclusion criteria, they did exclude patients who had intubation needs that might have prevented us from being able to collect adequate blood pressure data. They also excluded those who had contraindication to the interventions in the parent trials, as well as those who were pregnant or incarcerated. So the intervention or exposure of interest was yes or no, did these patients receive prophylactic vasopressor? And so this was defined as either a vasopressor bolus at the time of intubation induction, or a new vasopressor infusion, or an increase in an existing vasopressor infusion. And again, these agents had to be, or these dose changes had to be done around the time or concurrently with the induction agent being given during RSI. So because this was a retrospective study, they were very stringent about these criteria so that they could closely relate the event of the intubation to the administration of these blood pressure agents. The primary endpoint in question was the incidence of peri-intubation hypotension between the time of induction and 2 minutes following endotracheal intubation. And this study, interestingly enough, only defined hypotension as any systolic blood pressure below 90 millimeters of mercury. So they looked at just the 2-minute time frame after induction, and they only looked at this 90 millimeter mercury blood pressure parameter, which is interesting because in the Intube data and as well as some of the other hemodynamic RSI studies, they usually define systolic blood pressure below 65 for one measure as being hypotension, or a sustained blood pressure below 90 for 30 minutes as being hypotension. So this was a little bit more of a liberal definition of hypotension, and I think this was likely because of the more stringent time frame as well. Secondary endpoints included the change from baseline in systolic blood pressure from baseline to lowest recorded value. They also looked at the rate of new initiation of vasopressors or dose increases in the vasopressors. They looked at cardiac arrest within 1 hour of intubation, 30-day in-hospital mortality, duration of mechanical ventilation up to 28 days, and ICU length of stay up to 28 days. Moving on to results. So out of the 1,873 patients in the bougie and prepared to cohorts, 75 were excluded because they experienced a cardiac arrest, according to the data collection. The remaining 1,798 patients were available for propensity matching. So what they did was they evaluated all of these patients and found that only 187 patients out of all 1,700 received prophylactic vasopressors. So they took these 187 patients and they matched them with their best match from the remaining pool of 1,600 patients. So the final group for this retrospective analysis included 187 patients in the prophylactic vasopressor group and then 187 patients in the no prophylactic vasopressor group. So before I go into more results, I wanted to briefly touch on the baseline characteristics of the overall large cohort. So this is the group of 1,800 patients, and then excluding the cardiac arrest patients, of course. And we can see that the groups were not balanced at baseline. The patients who received vasopressors out of the large cohort tended to be older. They tended to have a lower pre-induction systolic blood pressure. They were more often in the ICU with a diagnosis of sepsis, a higher Apache 2 score, and more of the patients who did not receive vasopressors were actually admitted for trauma. Regarding the trauma admission and the difference between groups there, I think it makes sense that more patients in the no vasopressor group were trauma admissions because typically in trauma, patients may be allowed to be permissively hypotensive to prevent exsanguination. And because blood products tend to be more of the mainstay of therapy there compared to pressors. But based on this, the groups were overall unbalanced beforehand. Patients who received vasopressors tended to be sicker, and this made sense based on risk factors for peri-intubation hypotension. When we take out the patients and we go on to the propensity matched group, overall they were able to match most of these characteristics. However, a few more patients in the no vasopressor group had COPD, and again, there were more trauma patients in the no vasopressor group. But overall, in this smaller propensity matched cohort, the median age was 61 years old, majority were male, pre-induction systolic blood pressure was 110 millimeters of mercury. Most of these patients were intubated in an ICU, with the primary diagnosis being sepsis, Apache 2 scores of 22 to 23, and most of these patients received etomidate as their induction agent. The primary outcome of this study was peri-intubation hypotension, and in the propensity matched analysis, there was no statistically significant difference in peri-intubation hypotension. There was a numerically higher incidence in the vasopressor group, but this was not significant. And this made sense that there was no difference because we ended up really balancing out a lot of the risk factors that lead to hypotension when we did the propensity matching. Interestingly enough, the rate of hypotension here was 40% in the vasopressor group, which is in line with the previous studies that look at a wider time frame. So it seems almost as if in this study, there was a higher rate of hypotension in the first 2 minutes following vasopressor use. But I think it was because they had a looser definition of hypotension, with patients experiencing just one systolic blood pressure below 90 being included as having experienced intubation. For secondary outcomes, there was no difference in the change in baseline systolic blood pressure. Overall, patients' blood pressure decreased by 11 to 12 millimeters of mercury. There was also no difference in cardiac arrest in the first hour or 30-day mortality. However, there was a statistically significant difference in the new initiation of vasopressors. So patients in the vasopressor group were more likely to have new vasopressors added on or an increase in vasopressor dose compared to those who did not. There was a subgroup analysis that took out all the patients who were already on vasopressors and only analyzed 84 patients in each group who were not previously on vasopressors. And when they removed patients who were already on vasopressors, they saw actually no difference in new initiation of vasopressors. Here is a graphic of the survival of 30 days, and as you can see, throughout the 30-day time frame following intubation, there really was no significant difference in mortality between those who received prophylactic vasopressors and those who did not. So the authors concluded that based on the results that they found, administration of prophylactic vasopressors was not associated with a lower incidence of peri-intubation hypotension, and they felt this data was consistent with prior studies that looked at pretty much the similar outcomes. I felt that the strengths of this trial was that they included, even though it was retrospective, they included data from parent trials that were conducted by the exact same group of researchers with very similar inclusion-exclusion criteria, very similar data collection methods. They weren't retrospectively looking for data that had not previously been connected or been tangentially collected, but rather things that were on an existing data collection sheet that had already been collected prospectively. I feel like that may help reduce some bias that comes with retrospective studies. Additionally, I felt that this cohort was very reflective of the typical patient we see getting intubated in an ICU or an ER who present with sepsis, who may be ill-appearing or have respiratory distress. And finally, I felt that the rates of vasopressor use were very similar to other studies, so there is external validity here. However, because it was a retrospective analysis, I felt that not all covariates could have been balanced, and as a matter of fact, not all covariates were balanced. Throughout the study, it felt like there was really confounding that just would persist throughout every step of the data collection, because those who received vasopressors in the original cohorts were definitely predisposed to poor outcomes. They were sicker to begin with. They might have already been on vasopressors. When we try to account for that, we took out a lot of those baseline differences, and it really didn't give us meaningful data. Additionally, I felt that the study did not do a great job of evaluating the effects of different vasopressors. It would be interesting to see if maybe going up on an infusion compared to giving a push dose of phenylephrine or a push dose of epinephrine would make a difference in post-intubation hypotension as well as outcomes down the line. Additionally, I felt that the limited time frame made it difficult for us to really evaluate if maybe there was hypotension later on. Other studies use a 30 to 60 minute post-intubation time frame. I understood that they narrowed down the time frame to get rid of some of the confounding that might come from maybe sedation, infusion starting, or other interventions happening in a retrospective study. But this prevented us from really seeing long-term effects in an ER setting or in an ICU setting where we're potentially emergently intubating a patient. Can be difficult to maybe check a blood pressure every 10 seconds or every 30 seconds. So I'm curious about how many patients only had one blood pressure reading in the first 2 minutes, or how many patients had 10 or 12 blood pressure readings in these 2 minutes. I think that might make for some different outcomes if we had that information. And then finally, like I've mentioned, there really was no standardized frequency of blood pressure measurement. And so we're not sure how much of that data was accurate, whether or not patients were more hypotensive at times and they just weren't catching it. So my bottom line is that I felt the data from the study is not sufficient to demonstrate a benefit in using vasopressors. I also feel like it is not really a sufficient deterrent to using it either, because of all of the confounding that happened. Patients in these original cohorts had more risk factors for hypotension. They had more higher mortality risk to begin with. And so for me, I feel like there's insufficient evidence to go for or against prophylactic vasopressors in our patients. I think that we should continue looking at the whole patient and deciding whether or not we need a little bit of help at the time of intubation, and that it should still be up to the provider and the team at hand. So these are my references, and I would like to thank Dr. Supreme for her help on this journal club. With that, I am happy to answer any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.